Well, good morning. Thanks for joining us for this week's PGY2 Pain and Palliative Care webinar. We're pleased to once again have Dr. Brad Rea, PGY2 at Hospice of Southern Illinois, presenting this week's seminar topic, which is central post-stroke pain. As a reminder, next week's webinar is actually canceled thanks to ASHP, and most of us will be traveling back from that. The week after that, our presenter will be Brittany Johnson from University of South Florida. So with that, I'll turn it over to Dr. Rea, and thanks for joining us.
Thanks, Chris. So as he said, today I'm going to be talking about central post-stroke pain syndrome, or having pain after someone has a stroke. So what is central post-stroke pain? It's a form of central pain, or that's typically how it is described. Some of the descripting factors or descripting symptoms you might experience are fatigue, depression, and then the central kind of descriptors, much like neuropathic pain with tingling, changes in autonomic function and physiologic function. It used to be thought that it only occurred when a patient had a thalamic lesion, so a stroke, either hemorrhagic or an infarct that was in the thalamus. But as we starting to learn more about central post-stroke pain, it doesn't necessarily have to be in the thalamus of the brain. It can be in other areas like the brainstem and still actually develop this disorder. One of the big problems with it is it's under-recognized, and it's really hard to determine who actually develops the disorder and what is the actual chance of getting this pain syndrome. When you look at studies, they range from an incidence of 5% up to 70%. So there's no really good gold standard of how many people actually develop this pain, but we do know it is under-recognized. And along with this condition, we do have a lot of co-occurring conditions such as fatigue, depression, and a decreased quality of life. And I'll talk a little bit about that, of how these different co-occurring conditions might actually cause a patient to be at a higher risk for developing this pain syndrome. It's often described as indescribable, so it's hard to describe this type of pain that they do have, but it's nagging, it's typically constant without going away. And it really deteriorates motivation, which can lead to some of this depression and decreased quality of life because they are in this constant pain typically. So as I said, the epidemiology, this says 8 to 46%, but there are studies that say that the prevalence is greater than 50%. As far as age goes, there have been studies that looked at patients that have a stroke in the 6th decade of life and the 7th decade of life. There was no statistical significance saying that the younger patients were more likely to be affected. However, it did trend towards statistical significance. So in some ways, it is clinically significant that younger patients may be at a higher risk for developing central post-stroke pain. As far as gender goes and who actually develops this disorder, it hasn't really been determined whether it's more likely to occur in males or females. However, we do know statistically that males are more likely to develop a stroke, so there should be more males that do have central post-stroke pain just from that statistic. And as far as when this happens, it can really happen at any point after a stroke. There has been documentation almost up to a decade past actually having a stroke and developing this disorder. Typically, it's about 3 to 6 months that they will actually start developing central post-stroke pain, although it can happen immediately after the stroke. And really, it depends on the location as to determine when this will actually develop. Now, the pathophysiology, I'm not going to get into it a whole lot because we really don't know a whole lot about it, much like other central pain syndromes. We do know that it likely has to do with hyperexcitation of the damaged sensory pathway neurons, and then the damaged central inhibitory pathways. So really what we're thinking about is sensitization in the thalamic nuclei, and that being the responsible party for most development of central post-stroke pain. Although, as I've said, it can happen extrathalamically, so it doesn't have to happen in the thalamus. So we don't know a whole lot about the pathophysiology other than it is similar to the developing of like central sensitization, other central pain syndromes. As far as diagnosis, with many other conditions that have to do with central pain, it's typically a diagnosis of exclusion. However, there are some things that we have to look at to see if it is appropriate to diagnose them. So obviously the patient would have had to have a stroke, whether it be a hemorrhagic or whether it be an infarct that doesn't cause hemorrhaging. That is to be determined. However, really it just says that you have to have a stroke and you have to have pain after that stroke. It doesn't really specify what timeline it has to happen, since it can happen up to a decade later, but the pain does have to follow the stroke. Now, if you have pre-existing pain and then you have a stroke and have worsening pain, that can also be central post-stroke pain, which has to be taken into consideration. Another thing that was more common previously, and now we're starting to see that it's not always true, but having a CNS lesion from the stroke, which, as I said, it's not always true. And then looking at the neuropathic pain aspect and seeing if there's any other reasons why they might have neuropathic pain, whether it be fibromyalgia, whether it be uncontrolled diabetes that have led to peripheral neuropathy, whether it has to do with herpes zoster and post-herpetic neuralgia. So these are the kind of criteria to kind of determine if it's appropriate to diagnose central post-stroke pain. But as we know, there is no gold standard as of now how we definitively diagnose it through either laboratory testing or physical findings. So as far as the risk of central post-stroke pain by thalamic origin, now I'm going to get into this a little bit. There was a study that was done with 20 patients. 10 patients had a left hemisphere stroke, 10 patients had a right hemisphere stroke, and then 10 patients had a placebo where they had a stroke, but they didn't have the CSPS. I'm going to start calling central post-stroke pain CSPS for a shortened word. And what they did is they looked at these patients and they looked at MRIs to determine where these actual strokes had occurred or these infarctions had occurred. And we found that a lot of times they were in or around the thalamus of the brain. But we also know now that it doesn't necessarily have to be in the thalamus of the brain. So they actually took lesions, and you can see here by this picture that on the A or the top, that's the patients that had the central post-stroke pain. And on the bottom, these are patients that had strokes that didn't have central post-stroke pain. And what we had found is that patients that had central post-stroke pain were more likely to have lateral or posterior thalamic lesions, as opposed to patients that did not have central post-stroke pain. They were more likely to have medial lesions. So here you can see the thalamus. So they had them in these areas, the lateral or the posterior, they were more likely to actually develop this post-stroke pain. And another thing the study found was that larger lesions are more likely to cause pain, which kind of makes sense. I mean, the bigger the lesion or the bigger the area of infarct is, the more likely something's going to be messed up to cause some type of pain. But more importantly than the actual size of the lesion is the actual location of the lesion and where it happens. And as I said, the lateral and posterior thalamic lesions are the most likely culprits into developing central post-stroke pain. Some other areas in the study that looked at where patients did have central post-stroke pain were the brainstem and cortical regions of the brain. Like I said, it doesn't have to happen in the thalamus, although in the beginning and oftentimes it does actually occur in that area. So again, here's just kind of a picture of the thalamus, and then it's kind of blown up to a bigger form. And this picture essentially, green means good, so the medial or the median. If it happens in that area, you are less likely to develop central post-stroke pain. And in the red area here, the lateral, that's actually you are less likely, or you are more likely to develop this pain syndrome. So the area of the thalamus or the areas in the brain it does affect whether the patient, or the risk, whether the patient is going to actually develop post-stroke pain or not. As far as areas of infarct outside of the thalamus, there was another study that looked at, okay, how many patients with central post-stroke pain are having this pain outside of the thalamus? And they included 319 patients that had strokes in this study, and 66 of them had CSPS. As you can see, about 21% of them actually had developed the disorder. And then they actually went out and looked at how many of them were hemorrhagic, how many were ischemic, and how many didn't have a lesion at all. And you can see in this study particularly, actually more patients had extrathalamic lesions being developed as opposed to the thalamic lesions. So the thalamus was the most likely lesion location for the pathway, but they found that 2/3 of the patients who did develop CSPS pain do within the first month. And as I said previously, it usually happens within 6 months. 3 to 6 months is what other studies say. This study looked and said that usually within the first month they would develop pain. However, later on I'm going to talk a little bit about how there are some studies to contradict the fact about developing CSPS pain within the first month. So within this study, they also looked at treatment, and they looked at pregabalin. So essentially what they did was looked at pregabalin, seen if it was effective, and they assessed it after 2 months of therapy. They assessed it to see if they had a 50% decrease in their visual analog pain scales, and they found that most patients did. The average dose was 410 plus or minus 100 milligrams of pregabalin per day. And they found that there was a statistically significant difference if the patient was younger than 60 years old. So what I'm saying is, if the patient was younger than 60, there was more likely that the patient would respond to pregabalin therapy at the range of about 400 milligrams per day in treating their pain, as opposed to if they were greater than 60 years old. They could still actually be helpful. It's just that when comparing younger to older, they found that statistically and clinically that it was more beneficial to start pregabalin in patients that were younger than 60 as opposed to patients that were older than 60. So clinical features, what are we actually looking for? So typically, right lesions are the ones that are going to predominate in central post-stroke pain. And they are also more likely to cause anosognosia, or unawareness of suffering from a disability. So a lot of times we'll see this in psychiatric disorders such as bipolar or schizophrenia, where they have a disorder, but they don't intuitively know they have it, or they have very poor insight into their own disorder. So the right side of the brain causes this more frequently if they do have a stroke. As far as the distribution and the pain, it's often diffuse and difficult to characterize. And as we know with strokes, right-sided stroke will usually cause left-sided numbness or pain, as is opposite true for the left side of the brain. As far as the characteristics of the pain, it can feel like it's on the skin. It can be very deep. It can feel like it's bone pain. There is no set concrete descriptor of how these patients feel pain. It can essentially be any type of pain, from throbbing to stabbing to burning to tingling to numbness. There's all types of different factors that go into a patient's own understanding of their pain and their own feeling of the pain. As far as the characterization of pain, there's usually 3 components. So there's usually a spontaneous constant pain, which is almost always present. So this is something they're going to live with for the majority of their lives if they don't seek treatment. There's also intermittent pain that happens, which is intense pain that usually lasts for a few seconds. And then it can vary from up to a minute. And then they will go through essentially pain-free intervals where they don't have this intermittent component. And then we also have the typical symptoms of central pain syndrome, such as hyperalgesia, hyperpathia, hyperesthesia, and allodynia. So these are also commonly occurring in patients that have central post-stroke pain. A lot of times patients will complain of musculoskeletal pain as well. And this is typically in the shoulder area. And it is most likely related to motor dysfunction, spasticity, and a restricted range of motion. And I'll talk about a little bit about the risks and the actual percentage of patients that go on to develop central post-stroke pain versus actually developing just a musculoskeletal type of pain after a stroke, which is on this slide. So there was a study where they included 364 patients, and they looked at what was their incidence. So these were patients that just had a stroke, not necessarily had central post-stroke pain, and looked at how many of them had central post-stroke pain, how many of them had musculoskeletal pain, how many have had combined pains, other pains, or no pain at all. So you can see from the percentages, they're about 3 times as likely to have musculoskeletal pain as opposed to central post-stroke pain when they were actually looking at this. But the difference in the two is that the central post-stroke pain was associated with fatigue, depression, and poor sleep quality. The musculoskeletal pain was not statistically significant in influencing any of these symptoms. And the reason why fatigue here is in red is because the fatigue was associated with an increased trend towards depression and a decreased sleep quality. Also, it was found to be the most important independent factor for developing central post-stroke pain. So patients that have extreme fatigue post having a stroke are more likely to develop central post-stroke pain as opposed to patients that do not have increased fatigue. Now, that can't go on to say that because a patient has fatigue that they're going to develop it. It's just that they are at an increased risk. And they also found that, again, thalamic lesions are most likely to cause central post-stroke pain. You can see here by the intensities of the pain that even though the musculoskeletal pain is a lot higher risk, the actual pain level is much lower compared to central post-stroke pain. So you can see here it's almost twice as high as far as on a visual analog scale mean. And then obviously combined pain is going to be higher when you have the musculoskeletal pain in addition to the central post-stroke pain. So as far as the musculoskeletal pain, I'm not going to talk about it too much because it's not really having to do with central post-stroke pain as much as I would like to talk about. However, typically for that, you would use NSAIDs or antispasmodics to help treat some of that pain. Since it is typically a lower intensity pain, it's not usually as problematic to patients' quality of life. So as far as the prevalence and time course, so when does this typically happen? As I said in a previous study that I had mentioned, that it was typically within 1 month. Well, this study found that there was a prevalence as high as 30% of patients that have a stroke will have central post-stroke pain. And what they also found is that they looked at the timeline of when these patients will actually develop this disorder. So as you can see here by the chart, that 71% of the patients didn't have any pain. However, 5% had acute pain, 14% had subacute pain, and then 10% had chronic post-stroke pain. So this was essentially at what time did the pain actually develop. And what they found was that as far as musculoskeletal or shoulder pain, it was usually in the subacute or chronic phase. And then as far as headaches, which are commonly found in central post-stroke pain patients, now it is not specific, and looking at different studies, some studies include that for a diagnosis of central post-stroke pain, some do not, depending on the study. But typically when patients have headaches post-stroke, it's in the acute phase and not so much in the subacute or chronic phase. I thought that popped up right away. I am sorry. But here's essentially the pie graph that I was talking about. So as you can see, 71% have no pain, and then roughly 30% do have some type of pain that was either acute, subacute, or chronic. So treatment, how are we going to treat these patients? Well, unfortunately, patients with central post-stroke pain have no options that are FDA approved. We will treat them similarly to how we will treat other neuropathic disorders with antidepressants, anticonvulsants. Opioids can be used, I'll talk about a little bit, but not generally very effective. And then we have some other options that I will talk about. So the first one I will talk about is the antidepressants. So amitriptyline has been studied pretty extensively. And typically the studies, or the big study that has looked at it, started at 25 milligrams daily and increased up to 75 milligrams. Now it's important to start these medications low because of the anticholinergic side effects and risks associated with these medications. However, really, when you start low, you don't get a good benefit until you get to about 75 milligrams per day. That's when you start actually getting a decrease in pain levels with these patients. They also looked at to see if you can use amitriptyline shortly after a stroke to prevent post-stroke pain, and they could not find any benefits of doing that, to actually try to use it as a prophylactic agent. I say more effective than gabapentin because there was one study assessing amitriptyline versus gabapentin, and they found amitriptyline trended toward significance as being more efficacious and decreasing the visual analog score scales. However, this was in patients who had central pain associated with a spinal cord injury, not with patients that actually had central post-stroke pain. So although they both are central types of pain, they are different. So we can't make too many conclusions from that alone. Fluvoxamine has also been studied, 50 milligrams daily up to 125. So all of these medications were started at a lower dose and increased as side effects were tolerated. And this was found to actually decrease visual analog scale scores by about 1.7. So patients in the study typically had an average of 7.7 visual analog scale, and after 2 weeks had decreased to 6. Now, with other antidepressants, such as ones that don't affect things outside of serotonin. So I'm talking about things that only affect serotonin, like citalopram or SSRIs, much like other central pain syndromes and other neuropathic conditions, they are not going to be effective in these patients or will have minimal efficacy. So obviously we're going to want to use something that has other neurotransmitters like norepinephrine. As far as the anticonvulsants go, I'm going to go into a little bit more about these because there's actually quite a bit of data out there as far as anticonvulsants and central post-stroke pain. One of them is looking at lamotrigine. So there was a study that essentially started at 50 milligrams, went up to 200 milligrams, and they found a 2-point drop in visual analog scale after 2 months of treatment, which was statistically significant while being well tolerated. Now, obviously, if you're going to start patients on these, you want to talk to them about the risk of a rash and what to do if a rash does occur, because obviously Stephen-Johnson syndrome is a very serious condition. So we always want to keep that in the back of our mind when starting this medication in the patient. As far as gabapentin, it also has been studied, and it also has been very efficacious at a relatively low dose. So the study that I'm talking about was 300 milligrams twice daily, which, as you know, that's a small dose. 600 milligrams daily is not a very big dose. And so on gabapentin, realistically, you can go up to 3,600 milligrams daily in a patient with normal kidney function. And what they found that there was a 3+ point drop on the visual analog scale that was statistically significant in 60% of the patients. Now, what is some problems with this? Well, this study was done in Iran. So can we conclude that it will also be the same in patients that are being treated in the United States? No, not necessarily. We have different demographics. We have different genomics and genetics within the two areas. So it's hard to completely bring that across. However, I mean, this is a significant pain reduction for a relatively small dose of a drug. Pregabalin has also been studied, and at first, the study that I'm going to talk about had 219 patients. And what they found is that they couldn't find a change in pain versus the placebo. They started at the typical 150 milligrams daily and increased to 600. However, they did see improvements in sleep, anxiety, and the clinician's global impression of change. So although it didn't decrease the patient's pain, it did improve other side effects or other symptoms of the condition. And as I mentioned this one earlier, this study of pregabalin, which was more recent, actually did show a positive response in patients. So I would be more inclined to look at this study in determining if pregabalin is beneficial in patients, which did find a statistically significant difference in pain. Some other anticonvulsants that I'll bring up, so carbamazepine. So all these have been studied, but most of these medications in central post-stroke pain have very little data, and most of the data that is out there is very small studies. So carbamazepine has been studied and has not shown any statistical significance in reducing pain, as well as valproic acid. And I throw clonazepam on here as well. It's not necessarily an anticonvulsant, but can be used for seizures. And then zonisamide has 2 case studies, so not very much data, but it has been shown to be efficacious in patients who did have thalamic strokes. So it is an option, although I wouldn't recommend it necessarily as a first-line option because it does have minimal data compared to some of the other anticonvulsants that I had mentioned and antidepressants. Some other ones, so opioids can be efficacious, however, they're generally not very effective. And the thing to remember about this is that we're talking about a central pain condition. And as we know, opioids can actually add to central sensitization. So I would strongly try to get away from using opioids unless they had some kind of pre-existing condition prior to their stroke that may warrant an opioid. But typically with chronic pain nowadays, we try to stray away from using opioids and use adjuvant analgesics to treat patients' pain. Intrathecal baclofen has been used, and it has been efficacious in helping to reduce central post-stroke pain. However, when looking at oral routes, even at high doses, it has not been shown to decrease the pain at all. Ketamine has also been studied a little bit, but really what they found is it should really only be used in refractory patients with central post-stroke pain because it only really has a short-term effect in controlling their pain. It hasn't been shown to have a long-term effect yet, at least in patients with central post-stroke pain. So some other things I'm going to talk about, which is more new, one of them is transcranial direct current stimulation, which is essentially a form of neurotransmission which uses a constant low current delivered to brain areas of interest via electrodes on the scalp. And this selectively triggers changes in neuron excitation in local brain regions. So there was a study that essentially looked at a decent number of patients. It was, I believe, 40 patients, and they looked at using this transcranial direct current stimulation 3 times per week times 3 weeks. And it was also placebo controlled, so they would have patients that would essentially have this on their head and feel like they're getting the TDCS while other patients actually got it. And as you can see here by the visual analog scale, their beginning pain levels were not that high, but there was a significant drop in their actual visual analog scale scores. And all of these listed are actually statistically significant. The one that's not listed is warm sensation or warm pain threshold, which would be past this, but that one was not statistically significant. Another thing we found when using this for only 3 weeks is that there was a significant drop there was a significant skin temperature difference from the left hemisphere and the right hemisphere, depending on where the stroke actually had occurred. And these are in degrees Celsius, but you can see it was almost 1/2 degree Celsius change after the end of 3 weeks using this thing. Another thing that was looked at was quantitative sensory testing. Now, a lot of times in patients with central post-stroke pain, what they are starting to find is that their sensations are starting to be decreased. They're starting to become more numb. It's harder for them to determine if a object is hot or if an object is cold or to feel pain from these objects. So they use quantitative sensory testing to look to see if this transcranial direct current stimulation improved that. And they did this by applying a thermode to the hand at a reference temperature at 30 degrees Celsius. And then they would increase that by 1 degree, either warmer or colder, and essentially until the point when the patient would feel it, and then the patient would press a button. And after the patient pressed the button, they would send it to a computer and say, okay, this is at the temperature the patient actually felt the warm or cold sensation. And they did this prior to this intervention and then post-intervention. So you can see here the cold sensation threshold. They started at 30 degrees, and afterwards, the patients felt the sensation about 1 degree Celsius warmer than previously. So their actual acuity and their sensation had improved. The same can go for the warm sensation threshold. It only took 6 degrees for them to feel it above 30 instead of 9. And then the cold pain threshold had also been increased. So you can see here, this not only the transcranial direct current stimulation not only helps pain and skin temperature differences, but also helps patients with their feeling and ability to feel cold and warm sensations. Another thing that has been looked at is Venom Acupuncture. So this was essentially including 20 patients where they had essentially acupuncture in different parts of their body. Now, they had a bunch of fancy names for them, but essentially the areas listed are the ones that they got their medication. They got in their deltoids, their trapezius, their mid-arm, their lateral quad, et cetera, et cetera. And they injected 2 times weekly times 3 weeks. And in this study, they had 10 patients that underwent regular acupuncture in these areas and 10 patients that actually underwent Venom Acupuncture. And they used a visual analog scale of 0 to 100. I'm not exactly sure why, but what they found was that there was a median visual analog score decrease in patients that underwent this Venom Acupuncture. Now, when you say Venom Acupuncture, I mean, what is that? So essentially what they did is they took concentrated Venom and they essentially diluted it to 0.005% using normal saline. And then that was what was essentially put into the acupuncture needles. So you can see here there was a 36.5 point decrease in visual analog scale scores compared to the placebo group, which was 11.5 points. So there was a statistically significant decrease in the overall pain in patients that had the Venom acupuncture for only 3 weeks. Another problem with a lot of these studies that I've talked about is that they don't really look at the long-term benefits. So whether these decreases in pain are acute or actually last a little bit of time can't really be assessed at this point. But I just want to give you guys the data out there, and especially some of this newer stuff with transcranial direct stimulation and Venom acupuncture. There's some new things out there outside of the typical medications we give that are starting to be looked at to see if they can actually help with conditions like central post-stroke pain. And other than that, guys, that is my presentation. So I will take any questions you guys might have now.
Wow, that is an in-depth topic. So, based on what you reviewed, Brad, we have we have so many patients that come out of, the local hospital with, some form or another of ischemic stroke. Should we be screening these patients much more readily? Do you feel like it's a big enough problem where this needs to be something that's looked at on follow-up? And if so, who should be doing it?
I personally do think it should be looked at a follow-up, and I'm not sure exactly the timeline of when patients, or if they actually have strict follow-up after a stroke, but I would say sometime within the 3 to 6 month mark, and maybe at a year, seeing if they develop this, because we really don't know the incidence, and it seems that a lot of it's more likely occurring than what is expected. And as far as who can do the follow-up, I think a pharmacist could do the follow-up. It's not necessarily as a big of a problem, because what we're going to do is we're going to treat them very similarly to how we treat other central post-stroke pains. I mean, a medical doctor could do it as well, but I definitely think we need to have better follow-up in patients who have strokes, especially if we have imaging to show that it's in the thalamus, where they have that increased risk, especially if it's in the lateral or the lateral or the posterior, where they're at the highest risk. I think that should definitely warrant follow-up. But even outside of the thalamus, as we know, you can have extra thalamic lesions and still develop this disorder. I think it's really important to start looking at these patients, because as you've seen in the one study, patients with this disorder average a pain level of like 6 to 7, which is relatively significant, since previous to the stroke, likely they were at a very low pain level or none at all. So I think it's important to follow these patients, and especially with some of the treatments and the dosages, like gabapentin, 300 milligrams twice daily, which is a pretty benign dose in patients with renal function that's normal. I think there's a lot of help we could give these patients in trying to look at them post-stroke and seeing if they're at a good candidate for drug therapy if they have developed this condition.
So two things to follow up to that discussion. I think it varies depending on the area that the patient is in, whether or not they're followed by cardiology or neurology after a stroke. And I wonder if a cardiologist would be as in tune with this as a neurologist might be. I guess is my one comment. And then the other question is, did you find any data, or you might have presented this and I missed it, where if the patient does have documented imaging or evidence of having a lesion in one of these high-risk areas of the thalamus, where the risk is high enough for this type of pain syndrome where it might be beneficial to start empiric therapy for neuropathic pain?
I didn't find any data like that. The only thing I did find was looking at amitriptyline in patients that were similar to that, and they didn't find any benefits in preventing this disorder. As far as things like gabapentin, I couldn't find any data with that. It was only amitriptyline, and it essentially said it doesn't work prophylactically.
Okay. And then I'm noticing that Dr. Strassos has a number of questions. I don't know if you're able to see them on your chat function.
Yep.
But those are certainly worth talking about.
Yeah, and the first question, do you think this is sort of a central wind-up phenomenon? I do. I think that it's very similar to other central pain conditions that we have. Now, there's a bunch of different central pain syndromes that we have, so it's hard to say one is like the other, but I think that it is very similar with the hyperalgesia, the allodynia, the central sensitization, all these problems that occur with these central pain conditions. I think they are very similar, and this is very similar. So is it fair to say the treatment is generally similar to neuro? I would say from what I found, the treatment is generally similar. Now, in other neuropathic pain conditions, a lot of times we might look at SNRIs. I couldn't find a whole lot of data on SNRIs for the treatment of this condition, but I think it would be a plausible treatment if you've went through the typical amitriptyline, gabapentin, pregabalin, lamotrigine, some of the anticonvulsants. If nothing's working, I think it's an option that we could use, but I think it's very similar to other neuropathic pain conditions as far as right now. Until we figure out more about what this condition holds, I think it's going to be very similar to other conditions. Most of these folks will present to primary care. What present to primary care providers? What are the take-home messages? I think for primary care providers, if they do follow up with them, they just need education on really the incidence of this. I think there's a lot of undereducation about central post-stroke pain that really needs to be kind of beefed up. Now, they might not need to know everything there is to know about it, but I think it is important for providers to realize that there is a relatively high incidence of patients that are going to have pain post-stroke directly due to that stroke that isn't necessarily going to be treated with things like opioids. So it's going to be a central pain, much like treating diabetic neuropathy or post-herpetic neuralgia. So we're going to use similar medications to treat it. But if they're unfamiliar with the actual condition and the risks and the actual pain associated with it, they might not be screening for something like that, which really could prevent patients from living to the highest quality of life that they're able to. So I think primary care providers just need education on the risks of pain post-stroke would be my biggest thing.
Okay. Thanks. Any other questions from any of our attendees? Oh.
I have not seen any data that looked at central post-stroke pain in relation to a virus. I didn't see, I mean, not say it's not out there, but it's not something that I had found.
Okay. Well, thanks once again for another phenomenal presentation. I learned a ton on this one. Just as a reminder, the links to the recorded webinars are available for access anytime you want on the member portal for Society of Palliative Care Pharmacists. And we hope that you all will continue to log in for these very informative presentations. So thank you, Dr. Rea, and I hope you all have a wonderful weekend.
Yep. Thanks, Chris.